About an hour ago.
Okay, perfect. So we should be in and out within about 15, 20 minutes max.
Okay, so we left,
Should have some more.
When plaque builds up and develops, the stuff that is laid down initially is invisible on a calcium score. The only way we could get this data would be an autopsy. We will not have symptoms, chest pain, angina, flunk a stress test, till we already have a 70% blockage.
that was easy.
Oh, good.
Hello, everybody. This is Dr. John Osborne, the preventive cardiologist that is the chief medical officer at ClearCardio. I am really excited today. We have a fantastic program. We have some wonderful people joining us. They just got their scan with ClearCardio, with our approach. If you have the disease, if you have plaque, if you have the most minuscule amount of plaque, we can both detect it, we can measure it, we can monitor it, but most importantly for you is we're really on the verge of helping to eliminate the disease, plaque, atherosclerosis, that still kills today about 45% of us. And many times the first symptom of heart disease is death. Sit back, relax, and we're going to take you on a beautiful ride through the hearts of Floyd and Claire today. So there's your liver here, there's your spleen, stomach is here, and this is your left kidney. There's your left adrenal gland here. See a little bit of the pancreas right here. And we can also measure this. So this gives me an idea if you have fatty liver, which is very, very common, so that looks good. So no issues there. Left kidney looks good. The right kidney is going to be a little lower, so we don't see that. It looks like there's probably a little cyst in the liver here. I don't know if they mentioned that to you or not.
I think, yes, one time.
Yeah. So I'm sure when they did the lungs, they probably noted that as well. But
Well, this was actually years ago. I
yeah,
think.
so these cysts are just fluid-filled cysts. I'd say probably at least 10% of us have one. Sometimes a lot of them. But we can actually, how we determine it's a cyst, we can look at the density of that, and the density says it's a cyst. So this is the density number.
It's
right
nothing you worry about, or you try to do
No.
the liver cleanses or the.
It's just
okay.
a fluid-filled cyst. Probably, they saw it years ago. Probably the same one.
Okay.
And the only reason I mention this is that, because on either past imaging or if they image you in the future, they'll say you got a little thing in the
But
liver, it's a
it's
cyst.
been-
Exactly. So I just say, this is a cyst, that's all it is. It's of no
Okay.
concern. And you can see actually there's another one here, right here.
Okay.
And some of the tissues we can measure the density, and that tells us basically if it's fluid filled or not. That trick doesn't work with everything though, unfortunately. So, but that tells us that's a fluid filled cyst. Hello everybody and welcome. This is Dr. John Osborne, the Chief Medical Officer of ClearCardio, and I have something really exciting I want to share with you. We now have a newsletter. So this newsletter is all of the great science that I look at every day and read and scour the medical literature for. Important studies, important outcome studies, new tools, new drugs, new data on nutrition, all of the different things that I commit my life and have committed my life to and am passionate about in helping me to further preventive cardiology. From new diagnostic tools to new blood tests, to new medications, to the latest on intermittent fasting and dietary approaches to help people live longer and better. So it will all be in our newsletter. It is great reading. The price is right too, because it's free. So please subscribe to our newsletter. Go to clearcardio.com, or you can click down below and get access to our newsletter. Whether you're one of our patients or not, it's all good. But I love reading. I'm a voracious reader. I love medicine, and I love finding all the little charms, little treasures out there that make me a better doc, that better inform me, and ultimately help people along the way. So please support my habit of finding the greatest, newest, most important literature, and I'm delighted to share that with you. So please click below, subscribe. We'll get you on the newsletter list, and I think you'll really find it fascinating. So again, click below, join our newsletter, and we'll be really excited to help educate, because we're in Texas, I like to say educate you on preventative cardiology and what the latest and greatest tools, tricks, and treasures are. So thank you again. This is Dr. John Osborne, the Chief Medical Officer of ClearCardio, and click below and get on that newsletter. Looks like the aorta is just a little on the larger side. Usually this is the ascending aorta, the part of the aorta that's coming right out of the heart.
That means more to you, right?
It'll then,
Okay.
Exactly. The ascending aorta is the aorta, the big vessel coming out of the heart. That's about an inch and a half or so.
Okay.
It'll come up, it'll loop, give off the vessels to the head, neck, and arms, brain, and then loop, and then head down to the belly. So this is the ascending aorta here, and then this is the descending aorta. But all that looks good. There's your aortic valve, so if you had leakage, narrowings, congenital abnormalities, malformations, rheumatic deformity, you can see all that. All that looks good. This is your mitral valve. Again, any congenital abnormalities, malformations, prolapse,
I used
narrowing.
to have mitral valve prolapse. I don't know if you're seeing it now, but
No.
okay.
Did we talk about mitral prolapse when we were on the phone the other day, or on the Zoom?
You know, I don't know, but I mean, I always had it and had to do the antibiotics for
Yeah.
the dentist, and
Let me tell you about mitral prolapse. So about 20 years ago, there's a paper published in the New England Journal of Medicine. So they looked in the prior 15 to 20 years, right? And so 35, 40 years ago, of all of the people having an echocardiogram, an ultrasound of the heart, we diagnosed mitral valve prolapse in 40%.
Wow.
4 out of 10.
Yeah.
Okay?
wow.
They then looked, so ultrasound got better, our definitions got better. They then looked in more contemporary echoes. Now it's about 1.5%.
Wow.
So 2 things may have occurred. I'll give you your choice. 1, there's a massive epidemic of mitral prolapse, and the vast majority, everybody got better. Or else we way overcalled it.
Yeah.
And
Somewhere.
whichever.
So getting
and
sick from all those massive antibiotics
so
for
we
the
gave
dentist
people,
is, yeah.
we wrecked people, gave
Yeah.
them a cardiac diagnosis, had them take antibiotics for naught.
Okay.
So, yeah. And,
All right.
and if you'd had it, we'd
Yeah.
see it here.
Yeah.
But no,
Good.
looks fine. So,
That's
sorry
good.
about all that.
Yeah. Yeah. Sorry
On behalf
about
of my
it. Sorry about
colleagues.
getting sick for
Yeah.
every time you went to the
Um,
dentist.
We can also look in the left atrial appendage. This is a little, I always think of kind of as a lagoon, if you will, that comes off the left atrium, and that's where blood clots like to form. So we can look at that. That looks good. Particularly people who have atrial fibrillation, that irregular heart rhythm that occurs more often as we get more mature. Those clots form in that little structure right here.
So no clots.
No clots. Wouldn't suspect it, but
Good.
we can double check on that. The left ventricle looks great. No old heart attacks damage, enlargement. Right atrium, left atrium all look okay. No fluid around the heart, no pericarditis. So all of that looks good. No holes in the heart, congenital abnormalities.
How do you decide which image to look at? When
Um,
there's 1,600 images of the.
Well, so what that means is that's all the little tiny slices.
Right.
And then we're gonna
Put it back
reconstruct
together.
all this in 3-dimensional. So here's a reconstruction of you. Speaking of that, so this is you shown in 3 dimensions
Alright.
here. So there's your breastbone, there's your ribs. Now I will say we'll get a little more quantitative in a moment. But as you look at the ribs, so there's your ribs right here, right? So the ribs are bone, right? So they're full of calcium, so they're pretty dense, right?
Yeah.
And I will say, if you look at the bones here, You can see they almost look a little washed out.
Yeah,
See that?
Mm-hmm.
So that's an implication about the bone density.
yeah.
Okay. In a moment, we'll do some quantitative stuff. But just looking at this, you can see, yeah, I wouldn't be surprised if you said you had some osteoporosis, right? Because normally the ribs, see how they look right there, pretty, dense,
Yeah.
like a rib. And you can see towards the ends, they kind of get washed out.
Yeah, but and they don't test that on the test. They always test the
Right.
hip bones
Right.
and the
So any bone can
Well,
fracture, right?
supposedly
But
full blown.
yeah, but where it really makes a difference is the hips, just because of the weight that they bear.
Yeah, that's where they test there.
And there are two things: the hips and then the vertebra, right? Because you can also
Yes.
get compression fractures, which are really painful, and so literally the bone just collapses, right? So you can certainly get rib fractures from osteoporosis. You can break any bone, but the ones that kind of really matter, that we see most often involved with osteoporosis, would be
Yeah.
the vertebra and the hips.
And the hips.
Yeah.
Yeah.
But we had one guy that we diagnosed with osteoporosis. He was a guy, because it does affect men. He didn't know it. He'd never been tested for it, and he actually broke a rib without any trauma, because his
Oh yeah,
osteoporosis was
I've
that
broken
bad.
That
bones,
was lead
toe
better, right?
bones with no
Yeah,
trauma.
right. And what happened was he fractured his rib. The rib broke, and underneath each rib is there's a little, you can see, kind of see this little indentation here? So in that indentation lies an artery, a vein, and a nerve. Okay, so on the bottom of every rib, there's an artery, vein, and nerve. So what happens is he broke the rib, which then disrupted the artery and the vein, and he ended up with a 4-liter effusion in the right lung.
Whoa.
And they said he had a pneumonia, right? And then they sucked out 4 liters of fluid from his right lung. So he just thought he had pneumonia, right? Well, he came in 6 weeks later to get a scan. We looked at his heart, obviously. But as I was looking at this, I go, you broke your rib. He said, what? Not that I know of. But as it turns out, 6 weeks beforehand, before the pneumonia, and you can kind of tell the age of the fracture by how it looks.
Right.
So you could say it wasn't an acute fracture, it was an old fracture, so it was probably 6 weeks or so. Anyway, what happened was he broke his rib without any trauma and had a lot of pain, and then he developed the pneumonia.
Okay.
So they never
Yeah.
figured out he had osteoporosis and he fractured a rib until 6 weeks later when we
Did
put him in our
this.
machine.
Wow.
Yeah. So
Yeah. That was David Ledbetter, right?
that is correct.
Yeah. I saw his video.
Yeah.
He's the
I saw
one that got
video.
me here indirectly, because then he called David Frost.
Frost.
Ah,
David Frost
okay.
called me.
Got it. So there's your scapula there, breastbone. There's the descending aorta heading down to the belly, right in the back there, running next to the spine. There's the ascending aorta here. That's where your spinal cord goes, right there. I can put that back.
It's pretty neat, isn't it?
Mm-hmm. It is.
There's your spleen down here. There's your liver.
So do we get this where you can be manipulated like that?
So,
Or we get pictures.
You'll get still images.
Okay, but-
I'll make some a little video here,
Or
but to
some
but to
notes,
play with this,
yeah.
that's where you get into the workstations, and
Okay.
those are the big ticket items.
Yeah. Okay.
But I'll make some
Okay.
movies here along the way, so I'll have some movies to show everybody here.
My doctor will be interested. She's real interested in the osteoporosis. There's some new technology now with that too.
Yeah, fortunately the good news is there's a lot of very, very effective tools, medications to treat it. There's the inside of your kidney, in case you ever wanted that. Looks like
Okay.
spleen here. There's your stomach. So all that looks good. What I'm going to look at now is these are the slices we were looking before. Remember, this is three-dimensional imaging. So here, these slices are like this. Here, we're going to take you and slice you front to back. So this is your diaphragm here, spleen, liver, right lung, left lung. We'll blow you up here. And there's your breastbone there. there's your spine. And there's that little schmutz right there we were looking at before. And then lastly, we're going to cut you with my magic machete right through the middle here. So there's your spinal column. Right there, there's your spinal cord. And then we can take this, make some measurements here. So this number here, 174, so if it's, now again, osteoporosis can be a little spotty, right? It can be worse in some areas and not as bad as the others. That 174, if it's below 100, that's 100% absolutely osteoporosis. If it's above 200, that's great. In the middle, but your 174, you can see the bones look fairly bright, which they should. So at least in the spine, I would say it's probably okay. But again, in the hips, could be a whole different story.
Yeah.
So, and then lastly, before we move on, there's your esophagus. We can do what I call the virtual endoscopy, where they take that video camera, put it down into your stomach and esophagus. So we can do the same thing for free. So this is the poor man's endoscopy here. So if there's tumors, masses, cancers, varices, hiatal hernias, anything like that, we can see, and all that looks good.
Yeah, they were talking about doing one on her, and I said, you wait a minute, maybe you won't have to get that done.
Yeah. So at least the esophagus looks fine. So, and then there's that little cyst I mentioned there. So why did they want to do an endoscopy?
No, it wasn't that. It was the biopsy
Oh, biopsy.
of
Got it.
the lung.
All right. So we'll move on here. And I will say, so all the non-cardiac stuff, we have a radiologist look at that. I just take responsibility for the blood vessels. But, doing 20,000 of these or so,
You get where you,
Yeah, you pick it up by osmosis. So I always have a gentle rivalry with my radiology colleagues to see if I know things that they didn't. So we'll see. All right, so we're now going to move, this is actually the low resolution data. Now we're going to move it to the high resolution data, which is the heart, okay? And her heart rate was absolutely perfect. And what we're going to do now is...
Was that on the medicine that I had to take?
Yeah, the little cocktail that I gave you. Yeah. So we kind of, everybody gets a little different cocktail depending upon the heart rate, blood pressure.
Right.
So I'd like to get the heart rate low 60s, 50s or so, and yours was 58. Gives us beautiful pictures. So what's going to happen now in the background is the computer is doing computing work. It's going to identify the heart here, and then you'll see in a minute, it'll remove all the other structures around it. And that'll identify all the blood vessels. There's your spinal cord there. We can remove that, put it back. And there's the liver here. These two vessels right here, disappeared. Okay, anyway, never mind. So what we're looking at now is just the coronary arteries. So there's the aorta, that big vessel coming out of the heart, and then these are the coronary arteries. And we can, just for fun here, I will put the rest of the heart back, just so you can sort of see that. So there is your heart. And make a little movie here. So that is you.
All right.
So there's the left ventricle, right atrium, left atrium, aorta, and then these vessels right here are the ones we're going to look at with a microscope in a moment. Make a little movie there.
Yeah. I think the girl's biology class would.
Exactly.
She can take it in.
So this is the right coronary artery that goes to the right side of the heart. We're going to take that vessel. In here, that's the same vessel, but now we've laid that vessel out in a virtual plane, which you can't really do, right? And we've then taken that vessel and cut it right through the middle. So we can see not just the channel where the blood flows, the lumen, but also we can see the wall of the vessel, because that's always where plaque starts. Okay? So that's what that would look like if we did all that. Please don't try this at home. And then over here, we've taken that vessel and we've straightened that vessel out. So this is the magic of the of computation these days. I call this cardiology CAD-CAM. Then we can take that vessel where these little green arrows are, And this will then create a cross-section of that blood vessel. So this is the cross-section right here. And then these are 1, 2, 3, 4 millimeters upstream and 1, 2, 3, 4 millimeters downstream. So we're going to put all this together, and here we're going to fly virtually right through your right coronary artery. So now, this is where I have to make an apology. So
Okay.
in the old days, when I started doing this 25 years ago, this is as far as we could take it.
Yeah.
About 4 years ago, we developed all these cool AI tools. And what the AI does is all of those millions of pixels coming out of the machine that make up this three-dimensional high-resolution image, as it turns out, all of those millions of pixels are encoded electronically with over 2,000 shades of gray. When we look at this, we call this grayscale, whether it's a CAT scan, an MRI, a X-ray, or whatever. Our eyes can see or delineate about 50 shades of gray. However, every pixel, technically voxel, because they're little boxes, is encoded with over 2,000 shades of gray. So imagine we can see red, green, and blue. Imagine we could see ultraviolet, infrared, radar waves, gamma rays, microwaves, etc.
Right.
So we go from red, green, and blue to seeing the entire electromagnetic spectrum.
Wow.
So that's what AI does. So it literally can see things, that was my apology, that
we
I
can't.
can't see.
Yeah.
Okay? Furthermore, if it does see anything, it will then quantify whatever it sees, the plaque, down to a tenth of a cubic millimeter, which is an almost infinitesimally small volume. And all of that was impossible to do up till about 4 years ago. So that's what the AI now will happen. So when we get the AI data back, it's going to look at this. I'm going to say this vessel here looks perfect. I don't see any plaque at all. However, I will tell you, the AI is better than my eyes.
It's going to come back,
Right?
okay.
So we'll see. Now, I will say, having done hundreds of thousands of these AI exams, here's the data. Because plaque is so prevalent and so penetrant, it is the leading cause of death in the US, it's the leading cause globally. 1% of us, when we use AI, will have a 0 score.
Right.
1%. 99% of us have a non-zero score, okay? And particularly if you, on the other extreme, we can now, because we have the ability to identify and quantitate it very, very accurately, of the 99% of us that do have some plaque, based on AI, that a third of us, because we have a staging system based on how much plaque
That's
you have,
what I was,
right?
yeah.
So 0 is 0, and then we have 1, 2, and 3. So mild, moderate, and severe, okay, based on how much plaque we detect on AI. So a third of us, no symptoms, feel fine, normal stress test last week, I like to say, right, which are not very sensitive at all. A third of us, when we do these AI exams, will have stage 3 plaque.
Right.
Okay.
A
Right.
third of it, okay.
A third, right? And
Yeah.
again, no
and
symptoms, feel
last
fine.
month, went to my cardiologist and had 0 calcium.
On the calcium, right?
Yeah.
So remember, calcium score is good,
Okay.
right? If you have a 0 calcium score,
Yep.
your arterial age is 39,
Okay.
okay?
And I doubt it, yeah.
However, when plaque builds up and develops, the stuff that is laid down initially is invisible on a calcium score
Right.
because it's lipid. We call it soft
Okay.
plaque, cholesterol plaque, lipid-rich plaque, all synonyms. That is invisible on a calcium score because it's a calcium score. As the plaque gets older, calcium will begin to
Okay.
develop in those plaques. Then we can see it on a calcium score.
Okay.
And about 10 to
That
30%
makes
of us will have a 0 calcium score, which is good. I'd rather take 0 than not 0.
Yeah.
However, 10 to 30% of us will have a 0 calcium score and yet
And
still
have
have detectable plaque.
plenty of plaque.
And as it turns out, the calcified plaque is, and I'll use an analogy I use all the time, that is the cinder cone. That is the extinct volcano. The lava that I really care about, the active plaque, the growing plaque, the plaque that can rupture is the term we use, break off, lake off, pop like a pimple, whatever, that causes heart attacks, is all the invisible lipid-rich
Soft.
plaque, soft
Okay.
plaque, right? So on a calcium score, I'm only seeing the tip of the iceberg. I'm only seeing the calcified plaque, and I'm seeing the plaque that I really don't care about. Now,
Right.
if you have calcified plaque, 100%, how did it get there? It went through lava.
Well, it
at some
had to
point.
go through the
exactly.
soft plaque.
So again,
the hard plaque.
it's a helpful test, and the way I think of it is, think of the calcium score like a mammogram.
Mm-hmm.
Okay, this is the biopsy.
Right.
Right? Because mammogram, we go, looks
Yeah,
okay, it looks
yeah,
not, right?
yeah.
You have false negatives, false positives. When we do this,
You're digging deeper.
yeah, I mean, it's binary, right? You got it, you don't have it.
Okay.
So, the rest is all,
You do a good job
Probability.
explaining it in a
well,
Layman's term.
layman's term.
Uh,
Yep, yeah.
just a little practice.
Yeah. When people stare at you blank, like, what'd you say? Yeah, yeah, you explain it well.
Well, I do like to say I am a pretty good translator between medicalese to human.
Yes,
You
and not
will.
everyone,
And
not everyone.
Yeah, a lot of my
Yeah.
colleagues
Yes,
just don't
they
get
just
that.
stick
They
with
don't
the-
translate,
yeah.
right?
Yeah,
So, and I'm going to tell you, having done thousands of these, I have to tell you, every time I do it, I still remember the first time, and it was just like
yeah, yeah. What?
this. So that's why I call this the virtual autopsy, right?
Yeah,
Up
it
until
really
we
is.
had this data, and then the AI added to it, the only way we could get this data would be an autopsy,
Right.
and we could only
Yeah,
do that
yeah,
once. And most
right.
people decline, it, right?
Yeah,
So there's the vessel, and
right.
particularly when we look at the AI, you'll see the lumen, the channel looks beautiful, but plaque always starts out in the wall of the vessel, okay? And early on, literally for years to decades, if plaque is getting deposited, the entire vessel will grow outward. So the
Okay.
channel is completely normal
Right.
until very late into this. So the vessel will grow outward to accommodate that plaque, to warehouse the plaque. Now, it can get to about double its size, okay? The entire vessel, right? Then the plaque begins to grow inward. We will not have symptoms, chest pain, angina, flunk a stress test, till we already have a 70% blockage.
Right.
So this is all on the inside, yeah?
Yeah.
Okay.
Right. So when it causes a blockage, we get symptoms, chest pain, angina, flunk a stress test. But that does not occur until we already have a 70% blockage.
Right.
So that's way
Yes.
late
Yeah.
into
Right.
the process.
And when you get
With
to
this,
the-
we can see what's happening in the wall of the vessel. And even, again, with a stress test, you gotta have a 70% blockage before it becomes abnormal. Plus, when we do stress tests, there's about a 25 to 40% false positive rate where the stress test looks funky. You probably had friends in your
Yeah.
family,
Yeah.
right? I had a stress test, it was abnormal. They go to the cath lab and say, it was fine,
Right.
right? 70% of the time, when you take people to the cath lab, we don't see any blockages,
Right.
right? 70% or 25 to 40%, you get a false positive, which generates a $20,000 invasive heart catheterization, hopefully no complications ensue.
Right.
25 to 40% of the time, even though there is a severe blockage, the stress test looks fine, which is actually
Yes,
even
and you go home and fall out.
exactly, right? And the thing is, the plaques that rupture, right, that cause the heart attacks, are never 70%, almost never. They're 20s, 30s, 40s, 50s,
Right.
where there'd be no obstruction of flow, your stress test would be fine, you have no symptoms. Those are the plaques, particularly ones that are more full of lipid or cholesterol, that rupture, and that's how you go from, I feel fine, normal stress test last week, because I just stick the knife in and twist it. And then you have a heart attack because one of those 40% plaques, full of lipid, fragile, buttery lipid stuff, will rupture, and within seconds to minutes, when that plaque ruptures, your body responds with trying to form a blood clot, and that is the final common pathway to what causes heart attacks.
The heart attack.
Or if
Or
that
stroke.
same exact process, right? So the same thing occurs in the blood vessels of the neck, and we call that a stroke.
When we get to me, that's what I will be very interested in my aortic valve. It had calcified and
Aha.
cut down the blood flow.
Got
That's
it.
the reason that they replaced it. So,
Yep. Well, we will be able to see all of that.
right.
And I'm sure,
I had to have some lava in there at some
exactly,
point.
right? And I'm sure before your aortic valve, right, you had a heart cath done, right? So the SOP in the old days was, even though we know you're going to the OR
Yeah.
to replace the valve, we would do a heart cath to make sure you didn't have blockages,
But
right?
the heart cath was at the last minute, wasn't it?
Yeah,
He didn't
right
have
before
symptoms.
surgery.
He had none. He was
Right before surgery.
Right.
asymptomatic.
So what's interesting is, and I've been doing cardiac CT for 25 years, for my patients that have valve disease that need surgery, none of them go to the cath lab because we use this for 5% of the cost and none of the risk
Right. I like your.
to know if their blood vessels are okay,
Yeah.
right? So the next vessel we're looking at is the LAD. That's the vessel that goes down the front part of the heart here.
Okay.
And again, take a look at that vessel here. Fly through that vessel. And I will say, now I have to say that with AI, I will say by eye, it looks great.
Okay, so you're looking at it now. It's not the AI.
Right, yeah.
Okay.
So we already set this up to AI to get processed.
Okay.
So that's happening in the background. So
Okay.
we'll have that here shortly. So that's the LAD, and then the other major vessel going to the left side of the heart is called the left circumflex vessel. And now sometimes we use two different AIs. There's the one based on this workstation here, and then there's a separate AI they use for that quantification. What happens, and you'll see that area here looks a little funky. Well, sometimes the computer gets confused, and if you look at this, you can see the vessel actually goes this way. So it got confused and it followed the wrong vessel. So that vessel's fine, but it looks a little funky because this AI chose the wrong vessel to follow. And you can see it just makes a little curve there. But here, so there's actually the left circumflex. The AI got a little confused, and this AI is usually pretty good. It's very, very rare when it does this, but you can see it actually chose the wrong vessel to follow, but here we can kind of do it manually, and all that looks good. So I would say by eye, all the vessels here look great. Okay, we'll see what
good.
the AI says. Now remember, only 1% of us are completely zero when we use the AI. Okay, then I'll show you just a couple other quick things here. We get this data for free. This will be particularly relevant to your husband. The computer will take the heart, chop the heart up into 17 pieces, and then measure the wall thicknesses throughout the entire heart. This is very helpful. There's a lot of conditions that can cause the heart to bulk up, to get thick. High blood pressure being by far the most common. And yours looks perfect, right? So
Good.
It's really
yep.
good.
Yeah.
I had high blood pressure since I think I was
It's
about
thick like
Well,
30
and-
or early 30s.
Well, and obviously it must have been well controlled because, you know, if the blood pressure is not well controlled, like any muscle, when it has to work harder, it bulks up. And we
Okay.
can see that when we
it's
measure the
thick
heart,
like that,
the thickness.
The heart muscle hardens and it doesn't pump right.
Exactly. We can also then, from all this data, determine the exact size, dimensions of the atria and the ventricles. So all of those look good too. So no enlargement of any of those chambers. And then we can also look at the valves. So here is what I call the surgeon's view of the aortic valve here. So the aortic valve is a tricuspid valve, meaning 3 leaflets. So there's 1, 2, 3. So it kind of looks like a 3-leaf clover, or a Mercedes-Benz sign, or if you're from the 60s, a peace sign. So whatever. So that's your aortic valve. So that looks perfect. So no narrowing, no calcification, no leakage, no congenital abnormalities, rheumatic deformity, etc. So all of that looks beautiful. And we can also look at that same valve in the X, Y, and Z axes. So there it is from that angle, and there it is from that angle. And we can also do the same thing with the mitral valve. So this is your mitral valve here. We can fly through it. So if you had congenital abnormalities, prolapse, narrowing, calcification, leakage, we can see all that. So here we are flying through your mitral valve. So the cool thing with this is we get this incredible data that we could never get with any other tool, looking at the blood vessels of the heart, being able to see what's happening in the wall that was impossible until we had CT. The AI will allow us to see stuff we couldn't see and then quantify it. But the other thing we get out of this is basically a very, very high resolution echo, right?
Yeah.
And we get that
Right,
for
and
free.
I've had, yeah.
Yeah. So we can look at all the structural things, the valves, the sizes of the heart, all those things we look for in echo. We get basically all of that data for free. And that looks beautiful. So no prolapse.
I like that.
Okay.
Gotta keep you healthy, take care of me.
And you can see
Yeah.
the mitral valve, this is diastole when the heart is filling, is open. So there's the anterior leaflet, the posterior leaflet, and then during diastole, the aortic valve is closed. So there's all the little trabeculations, the papillary muscles, the chordae, all those little structures there. So looks great. Okay, well, so we'll see what the AI shows
Right.
as far as that. But really looks pretty phenomenal here. Or as I love to say, you're just as beautiful on the inside as you're on the outside.
Yeah.
Your husband told me to tell you that.
Thank you.
All right. And I will make sure that we'll send you home with either a thumb drive or a disc with all of this,
Okay.
these pictures and the data and the lung pictures.
You
and all that.
know, one thing that I found, because I had a disc that came from somewhere, and I don't know if it's the different formats or what, but the doctor I went to, and it was after the pneumonia, they said, we can't
Right.
read this disc.
So what happens
I don't know
is
if you need both.
all
or-
of this data is encoded in, there's like JPEGs, right? So
Yes.
for visual pictures and all that stuff, all this data is encoded in a format called DICOM. So that is the universal language that all medical imaging is encoded in DICOM. So what you need is a DICOM reader that reads that data. Now, the discs that we create will have a DICOM reader on the disc,
Wonderful, okay.
right?
Okay.
However, anybody that has any DICOM reader can read any disc.
Right.
There's lots of different DICOM readers, but the disc we give you will have the DICOM reader
Already.
on it.
So,
But anybody, like radiologists, all the data they get, no matter which machine took it, which CT,
Right.
MRI, all that data comes to them as DICOM data. Then they have whatever DICOM
I was
readers.
surprised.
So yeah,
And then my family doctor, when I gave her the CD,
Mm-hmm.
and it was from she says, I don't even do a CD reader anymore. I'm like, okay. Yep. So I don't know if some have gone to the thumb drive or what.
yeah. I mean, we can do either.
And then
So.
then the pulmonary doctor said, well, we can do it, but we can't read. And this was from an emergency center in town. They could not read that particular CD.
Well,
So anyway, I just, yeah.
sometimes
I don't
when
know if
they
we
when
need
they
both.
cut the disc,
Mhm.
it'll have the DICOM data. Sometimes they don't put the DICOM reader on there. There's some generic DICOM readers.
Is it a problem to get both? To get the thumb drive and the disc?
No, we can do both.
I mean, is it, if it's fast
Yeah.
enough?
Yeah, we'll give
But
you both.
I was surprised because that was 2 doctors
Yeah.
that could not read that disc.
So either it didn't come with that software on the disc,
On
or
the
maybe
disc.
they didn't know to
How
boot
do-
up that software and then use that to
Right,
read the
right.
disc. So.
And this was a hospital. Yeah, you
Yeah.
would think they would.
Yeah, the radiologists, I mean, that because they look at this and use this all
Okay.
the time.
You
They
haven't
always
heard.
have their DICOM
Okay.
readers.
That's what they do.
Well,
Yeah.
you would have
I
thought.
would have thought.
All right, so that
Okay.
is you.
That's me.
Couple cysts in the liver, no big deal. We looked at the bones, we looked at the esophagus, that little schmutz in the right lower lobe there. But the heart looks phenomenal.
Okay.
Looks beautiful. Thanks everybody for joining us on this very special program. Of course, I think all our programs are special, but this has been a really remarkable day for all of us here, myself on the cardiology side, and I know for Claire and Floyd. It's been incredibly enlightening as you learned. But this is the ClearCardio path. This is the ClearCardio way, and I think, unfortunately, this is how everyone should proceed to help eliminate the largest cause of death by far in the U.S., which is cardiovascular disease. We're out there to make a difference, and thank you again for joining us today. But also be sure, sign up, click below, ClearCardio, find out what we're doing. We have lots and lots of great videos and educational aspects about how we can work to prevent heart disease and stroke for that matter as well. Please click below. Please subscribe. If you like this program, you want to see more, please subscribe as well. Please do that below. And until then, we're just going to keep working to eliminate heart disease at ClearCardio.